So I try to speak in language with flow, more flow. So I'll speak about practical neonatal echocardiography. This lecture is not for cardiologists, not for those who is doing advanced neonatal pediatric echocardiography. This is only for neonatologists in a setting where is the pediatric cardiology not available. So can do initial study, which help to have initial diagnosis. Sometimes also you can take decision, especially for ductus-dependent lesions, or for cases maybe need you want to start treating pulmonary hypertension, or you want to start treatment for PDA. I will start speaking about the basic about the echocardiography, but it's a basic. So it is not a big difference between machine and machine. As you know, there is many machines in the market. There is GE, which is the most famous, and there is a lot of generation from GE. There is Philips, Toshiba. So all of them the same principles, but you have to know that the machine is consists of from probes, different probes. Probes is where you put I mean on to take the windows, different windows, connected to the computer and control panel and the screen. So it's the same principle. In the machine, we have in the machine is we should know how to operate the machine, because if you don't know how to operate the machine, sometimes you'll be it will become I mean in the critical situation. First of all, the upper stage where is the off and on. Usually we press and still pressing until the green light is. I think most of the doctors, they do cranial ultrasound, or they do basic abdominal, or sometimes they want to put central line. Say most of the doctors in the units, they know how to operate the machine, but it's a basic just to press still, then the machine when the green light is coming, and follow up the instruction. Here we have the patient. So select the patient and put the data of the patient, because this is help you to save the data and come to it later on, because this is also for medical legal. Sometimes somebody said you have done, you have not done, from where is the diagnosis. Then if you save the data, you can come to it always. So you press patient, so in the screen will come data of the patient, like name, surname, the ID and everything. Date of birth, male, female, or anything. And under it, there is a probe. So you will select the probe and appropriate probe for, are you following me? Hello?
Yeah, it's clear, Ahmed.
Oh. So you will select the probe, and from a probe, it will come what kind of a probe you require, pediatric, adult. After that, you will select what kind of a probe you use. Usually for neonate, there is different from machine to machine, but usually the small head, and usually 10S or 12S, usually the smaller, and where is 4S or 6S, one is for adult, the 4S, and 6S for the pediatric cardiology. And usually straight, the probe for the cardiology straight, where is the cranial ultrasound like moon-shaped, concave for the cranium. Anyway, also can be used. I mean, the probe 12 can be used even the cranial ultrasound. Anyway, after you select what the probe, just put the jelly and see if the probe is, because there is most of the machines that attach for 3 probes, 2 probe or 3 probes. So you would like this is a probe is working. So just put the jelly and look at the machine. You see it's working. So this is a probe. Different. We will not go for different details from the machine, but most important. Here's the buttons for the gain, because you want to see how the clear is the image. Where is, of course, this is the mouse, how to move the arrow. Where is here, you have a color Doppler, the color, just the color, and the the M mode. The M mode, if you want to measure the ejection fraction, shortening fraction. 2D. This 2D, it is the echocardiography is 2-dimension, because you have the M mode and you have the 2D. Sometimes the phrase, just to phrase the image, when you press the 2D, the images will move. And you have the store. If you want to store that, just press two press. You store the image. And you have B1 and B2. This is the printer. Just press the B, then the printer will come. More details, I think those people who will conduct, interested in echocardiography, they will conduct the training, so they will know more about CW, about continuous wave Doppler. You want to know the velocity across the whole area, and the pulse Doppler in the certain area. Others, I think you will learn it later when you are interested to. So I don't want to waste your time unnecessary. Okay, this is a probe. This is a probe. So the probe, usually the probe there is a marker, where you will put it in certain place to have the optimal images. So we have pediatric. Here we have this pediatric probe, can be used for cardiac and neonatal cranial ultrasound. This is very quickly, but you should understand how the things is generated, and how the images is generated. Usually, the ultrasound sends a wave, which to the tissue is being studied, and the waves will be reflected and will be analyzed by the machine, by the computer, and generate the images. So the basic principle is the same, but you should know that the machine is very expensive. Machine is big responsibility. Most of the machine is like $100,000 US. It's a good machine for cranial ultrasound, so you have to take care. This machine is not easy. So most important, the machine is the probe. If you are moving the machine and the probe fall down and walking in the machine, you are spoiling the machine, because the most expensive is the probe. If the machine is 50,000, the probe at least 10,000, 15,000. So the probe down, which is explained that the machine sent electrical current to the crystal. This is very expensive, the crystal, and generates the ultrasound waves, and then it's reflect, and the machine analyze it and go and create the images. Here's a principal cut. When you cut, how you see the heart. This is in short axis and M mode. How when you penetrate the tissue, how it appears, and the transducer means the probe itself. It creates a beam and cut in the wave. So you should have good imagination when you are cutting the section in the heart. You should have good imagination where you are cutting and what you are expected in every. A general principle: when you start the procedure, always make sure that the room is dim, because you can't get good images and understand what is going on if it's bright room, and the jelly should be warm. So because it is very cold, sometimes there is in different units there is a machine which warms the jelly, but not hot, just for the to be friendly. And sometimes you need sedation. In the neonatal period, we don't use the sedation like for chlorohydrate, but if you're a child or pediatric, like 1 year, you can use chlorohydrate. For neonate, we use here sucrose. We give sucrose every unit, sucrose, which help to, because crying will generate air in the chest, and air is the enemy of ultrasound. So just general principle like this one, this apical 4-chamber view in 1-day-old neonate. This one in adult is the opposite. So the window which you use usually, most of the people, they prefer to make the window in the opposite side. So like what you use the probe in the same way the image is coming. So when you use for chamber view, usually you create it from the apical from the apical, and the marker of the probe should be the right side, and in the apical view you will have this view. So you have here right atrium, left atrium, and left ventricle, right ventricle, and the septum, IVS, intraventricular septal wall. Here you will see descending aorta, sometime precardial area, if you want to look for precardial sac, for any precardial effusion or anything in this place. So also you should have the art how to use the probe, how to move the probe. There is probing using the probe in different area, like sweeping like that, and moving right, left, rotating, all this different modality to use the probe. You should learn it also. Here in 4-chamber view, in apical 4-chamber view, how we see this is left atrium, right atrium, and you have the pulmonary vein also. The pulmonary vein, upper, lower, left, right, coming, and you have the mitral valve and papillary muscles, and left ventricle, right ventricle, and this is in 4-chamber view. In 4-chamber view, how to generate it, as we said, by putting the transducer or the probe in the apex, and the marker should be to the left. I will go for all details just like that. So this is windows. Well, this is the windows what we are here, subcostal windows or sub-xiphoid windows, and here long axis, and here as a short axis, and here apical and suprasternal view, and everyone we will explain how to get the view. So when you start the echocardiography, first of all, I like this way. I learned it in Qasim Prince Sultan Cardiac Center. I worked there for some time. So they teach me this sequences of examining the echocardiography. You start from the abdomen. So this is the probe, the marker to the left, and you put it in like 90 degree on the abdomen, and the marker to the left, and you will see this view. So you will see the vertebra, descending aorta, IVC inferior vena cava, and hepatic vein. So what is the benefit of this view? The benefit of this view to identify the situs of the heart. I mean, you are dealing with situs solitus, situs inversus. So dextrocardia, I mean, you are dealing with normal situs. So you are expected the aorta will be on the aorta will be in the left, and IV inferior vena cava in the right side. So how to differentiate between them? The inferior vena cava collapsing and thin wall, and the other is so it is not the color. The color in the color Doppler or the color in the ultrasound, the color is not, if it is blue, it is not vein, and the red is not artery. If it is red, that means it's coming to the word of the probe, and it is blue, it's away from the probe, just like the flow of the blood. So if the flow of the blood coming to the probe, that means it's red. It's away from the probe, it is blue. And as you see here, you are expecting because this is the artery, you expect pushing the blood down to the towards of the probe. That's why it's red, and it is blue because it's going up away from the probe. This is a basic principle of the echo. And here, after you are optimizing the images, you will see this image. So you have the descending aorta. This is the descending aorta, and this is IVS. And here is a vertebra. Is that clear? Hello? Is that clear? Hello?
Yeah, it's clear, but I need to hear from them. Dr. Nasser or Muhammad saying yes. So it's clear. Yeah.
So what I mean here, when you are doing start with the situs, and you identify this is normal or dextrocardia. It's very important images when you start. This is at the beginning. So after you start, you want to know if there is there is correctation, interrupted aortic arch. You do these images. You sweep the probe until you get abdominal aorta. You have here abdominal aorta, and sees the flow. And from the eyeball, you see it's good flow from the abdominal aorta. But you do CW. Put the cursor. This is the cursor, huh? And here is the marker. Put it here, and you will have this measurement. Usually, anything more than 10, it's normal. But if you see, it is very, very small, and it is showing very less flow. That you have to have suspicions. You have something obstructing the proximal before the descending aorta. This is the descending aorta and celiac trunk, and this is another view how to obtain it. As you see, when we do the situs, the marker was to the left, but just rotate it to 12 o'clock, and you will see the abdominal aorta. Abdominal aorta, you see it. You do the CW and see how the flow is going on. This is another view. I like it also. This view, because you want to do this view just looking for inferior vena cava and hepatic vein, and in relation to the right atrium. So you should have this one and know how the flow, and do also CW. And this is a way how to get this view. Okay, from subcostal view, the marker to the left side of the body, I mean, to the left side of the body, and do it from down and go up until you become superficial. You will see this is I mean, we call it bicaval view. So this is long axis, subcostal long axis, or coronal view. So you will start with what we call bicaval. Bicaval means superior vena cava and inferior vena cava, and the atrial septum. So if we work this one, you will see this superior. Yeah, this is superior vena cava, and this is inferior vena cava. And here we have the septal view. Usually any BFO, which is normal, and always put the color Doppler just to see. And sometimes you have to make double images, one with color, one without color. We will see some images just to compare and see. So here, how to get subcostal view, long axis, subcostal view. This the first one is left atrium, right atrium, and the atrial view, just to see the kind of any atrial lesions like BFO or atrial septal defect or AV canal. You will see in this one. So you will start superficial and marker to the left side of the body, and you move it up and down, and you see all the different images. So we'll start with bicaval view, which you see the atrials, and go down deeply, little deeply, and move it, which we have seen in this images, from up, down, and you see all different view, cutting different view. To see long axis, you will see the atrial first, then you see the ventricle, and in relation left ventricle to right ventricle, or the relation between the pulmonary artery and the aorta, how the relation between them. So this is, so as you see from also you will see if you go more down, and you'll see right ventricle outflow. It means the pulmonary and the pulmonary valve also. So this is the right ventricle, left ventricle, pulmonary valve, and right ventricle outflow, and you will see also pulmonary vein from this view. So here, how to do the long axis, parasternal long axis. You will go, usually parasternal long axis also, it is very helpful to see what is going on. Right ventricle, left ventricle, the IVS, I mean the ventricle symptoms, and also you will see the aortic valve. You will see the mitral valve in long axis. So here in this picture, this cartoon showing here how the marker to the right shoulder. So this is a marker to the right shoulder. Okay, this is to right shoulder, the marker, and how you cut the view, and what will appear. You see here what will appear. So it will appear right ventricle, aorta, and the aortic valve, aortic trunk, aortic valve, left ventricle, left atrium, and the mitral valve. And here showing where to put it and how to get it. Yeah. So the transducer is in the left sternal edge, second or fourth intercostal space, which creates right ventricle in the top, right ventricle in the top, and left ventricle down. And marker direction, as we said, to right shoulder. Sometimes you want to concentrate more on the mitral valve or to the aortic valve in this view. So you want to see there is atresia or stenosis or aortic leakage. You want to see the relation between the aortic valve or also if you want to see mitral regurg, mitral stenosis, or this one from this view, you can see from long axis. Also, sometimes from long axis, if you want to calculate the ejection fraction by M-mode, you just put the cursor here and cursor here in this area, and just to M-mode, and from M-mode you can calculate the ejection fraction. This is also another way from the long axis. You can, the right ventricle outflow, mean the pulmonary artery and pulmonary valve, and the bifurcation of the pulmonary artery. This is the right and this is the left, and in relation to the left ventricle. So this is the way how you put the probe and how you see the long axis. Now we will go for the short axis. Short axis, what we will see in the short axis. Again, also you have to imagine how we are generating short axis. We generate short axis by rotating the probe 90 degrees away from last time. So it was to the right shoulder, you make the marker to the left shoulder. So here we have 90 degree rotation of the probe. So when you rotate the probe 90 degree, you will create a short axis when the marker is going to the left shoulder. Right shoulder will always a marker will go, a marker to the left shoulder will create long axis view. So in short axis view, what benefit in short axis view? Actually, in short axis view, when you start from superficial, you will see this view. You will see right ventricle outflow, the pulmonary valve, the main pulmonary artery trunk. You will see left and right pulmonary branch. You will see Mercedes sign, and you will see the Mercedes sign for the aortic valve. You will see right atrium, left atrium, and also the tricuspid valve. Okay, tricuspid valve also will have benefit. And from this view, you can also see any defect in the ventricle septums from any level. You can generate those three views. It depends where you cut. If you very deep, you cut the apex, then you go up until you will see the level of the pulmonary valve. And this is another cartoon showing how you generating the short axis and the marker to the left shoulder. So the again in transducer position, left sternal edge. This how to generate, again explaining how to generate the short axis and how to do the short axis where to put a marker, as we said. Long axis to the right shoulder, rotate the transducer 90 degree clockwise until you generate a short axis. Again, this is in short axis, cartoon and explanation what you will see. So you have a tree cusp of the right, left, and non-cusp. For the aortic valve, you will have the pulmonary valve, right ventricle outflow, and the pulmonary trunk, and the deviation right and left atrium, right atrium. And you have also the tricuspid valve. All this, as you can see, in short axis. So, and again, this is in short axis, how you will see the view. And here, how, if you are cutting deeply, you will see the left apex. Here is right apex. So upper is the right apex and apex. This is if you go more superficial until the level of mitral valve. This is the fish mouth, and this is the level of the mitral valve. This is in short axis how you will see the two branch of. So here we have right and left branch of the pulmonary artery, right and left, and here we have the aortic valve, and this is the level of the pulmonary valve. If there is any stenosis, dooming, thickness, you will know from this area. And sometimes you do the color Doppler and see how the things is going on. Here, this is another view we call the ductal view. Just move the probe little upper and rotate the probe until you see the ductal view. We say this is the ductal view. This is patent ductal arteriosus, and from this is color without color, and the size you can estimate it by measuring the how big it is. So this is important for pediatrician, how to know the BDA and how to diagnose BDA from ductal view. This is how to obtain for chamber view again, and showing how if you went superficial, what you will see, you go deep, what you will see until you see the last one down. So you will see 4 chamber view, and then this is 4 chamber view, and this is 5th chamber view. This is sometimes you have to see 2 chamber view or 3 chamber view according what cut you will do and how much you see. If you go very superficial from down, how you move, you will see the right ventricle outflow and the pulmonary artery. This is benefit because sometimes you want to know this is transposition of great artery or not. So when you are doing, you will see the aorta coming more deeply and pulmonary up, and see how they are crossing. If they come parallel, then it is transposition of great artery. So this is how to put the probe and how to get the 4 chamber view. This is again how to get 4 chamber view or 5th chamber view. And here in this view, sometimes you see a coronary sinus here in this area, which is normal. Just make sure you know the anatomy and how to get this view because this is normal. This is a fifth chamber view. Left atrium, left atrium, left ventricle, pulmonary, aortic artery or valve, and right atrium. This is fifth chamber, we call it. And this is how to get short axis view from subcostal and what you will see in short axis view. Yeah. Remaining this important to know the aortic arch and how to get the aortic arch. Usually the aortic arch from a suprasternal view, and you will put it. You will put the marker to the left again. The marker is the left, and just put it in the suprasternal notch and the marker to the left, and sweeping the probe in different angles to get until you get this view. This is a view you will get, and the tree branch. And as you see here, the marker to the left, and you put 90 degree and start searching. So superior vena cava. Then you will aortic trunk and nominate artery, left carotid artery, and left subclavian artery, and descending aorta. And this is the view, what you can see here. This view is important to diagnose interrupted aortic arch, coarctation of the aorta, both of them. After you put color Doppler, then put the cursor on the Doppler and make CW, and you see if there is any turbulence or how much the CW is going on. And this is the echo for normal sound. Subclavian artery and carotid and innominate branch, tree branch. There is another view, advanced view, that's one we call a crop view. The crop view, it is to identify if there is total drainage anomalies, if there is any anomaly in connection the pulmonary vein to the left atrium. And relation, as you see from anatomy and as you see from cut, which is, and this is the crop view. So in the crop view, you'll see left atrium and left pulmonary artery, right pulmonary artery, and the relation. Here, 1 minute, just I show you here. It is here. Anyway, this is a way how to get the crop view. You rotate it and angulate it, rotate the marker to the left, and you will get the crop view. Here, how to get the M mode and how to calculate the ejection fraction. Ejection fraction is very important in dilated cardiomyopathy, hypertrophic cardiomyopathy. So in both sides, you will generate M mode, and you will take the measurement, and the machine will calculate for you the ejection fraction. So like you can do it in short axis here, as you see from short axis, you can do it from long axis, but you should be optimal, which is the cursor. This is the cursor. What's a cursor? From right ventricle to the IVS, and to the mitral, and it will give this view, or from short axis, optimize this one, it will give, but no difference. Sorry. So this is systole, this is diastole. Just measure from here to here, then from here to here, then from here to here, from here to here, and machine will calculate for you how much is the ejection fraction. This one important view because if you want to know there is a pulmonary hypertension, of course you will not put the cursor in the pulmonary artery and calculate. No, you will look to the tricuspid valve and see if there is tricuspid recurge, like here's a jet which is coming, and then you put the cursor. And when you put the cursor in the jet here, the marker and the cursor, and you do CW, so continuous wave Doppler, and it will calculate the peak velocity. Usually it will give number, like here, it give number here is giving like 76, sorry, and you will add 5 from the left at right atrial pressure, and we calculate both together, it will come 80, which has severe pulmonary hypertension. So how this is how to calculate pulmonary hypertension. Just you look to the TR, put color Doppler, see the jet, put the cursor, put the marker, put CW. You will see this view, and then measure. Just measure. This is marker from here and number coming, like 76, and you will add 5. It will be the total pulmonary pressure. And this is important in pulmonary hypertension to know it is significant or not significant, to start treatment or not to start treatment. Another view, but not important in neonate, but sometime in rare, very rare condition for anomaly of coronary artery, left coronary artery anomalies, which is very rare, but how to know where is the coronary artery from the short axis view and looking to the aortic valve area, and you will see this view. So from this view, you see this is right. This is a right. This is RCA, right coronary artery, right coronary artery. See? When you look at it, you see if there is any dilatation or anything. And even from this view, you can still see the LCA, left coronary artery here. And this is a benefit later on in Kawasaki disease, or see dilatation, but also important to know if there is the right, the left coronary artery is coming from the correct place or from another place, just to know the anomalies there. I think this is what we can speak about the basic echocardiography. So if somebody has any discussion, of course, I told you I am not a cardiologist. I'm not doing. I can diagnose some cardiac lesion, but not all. Of course, it is different specialty. But I learned the echocardiography because I was working in a unit where is no cardiologist in the area. you have to diagnose yourself initially, and so from practice, and close working with the cardiology and people who is coming to the area. So you will learn from them. But if you want to be able to do echocardiography, you need a lot of studies. Normal, then abnormal, do courses, YouTube, different. There is different. Website, Westage, online courses you can learn.